Okay, good morning, everyone. The topic that was assigned to me was in your handout, or was sent to you, was about fatty liver and your blood test. But I decided to expand the lecture to more than just the fatty liver disease, although that is common, but also to discuss some of the basics of abnormal laboratory liver tests or liver function tests, as well as discuss the abnormalities of liver testing and other diseases, because we don't just encounter fatty liver disease. So, an abnormal laboratory test or abnormal liver function test or liver test is not only caused by primary hepatic pathology. So, we all know that the liver is the largest organ of the gastrointestinal tract, and it has three systems. The biochemical hepatocytic system, which is responsible for protein synthesis, aerobic and anaerobic metabolism of glucose and other sugars, glycogen synthesis and breakdown of drugs, usually involving the cytochrome P450 oxidation system, and storage of iron and vitamins such as vitamin A, D, and B12, and synthesis of hormones such as angiotensin, insulin growth factor 1, and triiodothyronine, and coagulation factors. So it's also made up of the hepatobiliary system, which involves the transport of bilirubin into the hepatocyte and its conjugation to glucuronic acid and its excretion into bile canaliculi and the enterohepatic system, and the reticular endothelial system, specifically involving the Kupffer cells or your liver macrophages, which is responsible for the immune system, including being a major site of defense against intestinal bacteria and the primary location for removal of antigen antibody complexes from the circulation, and with the breakdown of hemoglobin from dead erythrocytes. We know all the usual signs and symptoms that points to a liver disease, like upper abdominal pain, jaundice, colic stools, darkening of urine. But some patients have abnormal liver tests despite of being asymptomatic. So this is an algorithm of how we work up, or how our clinical colleagues work up abnormal liver tests. So the liver tests that are routinely ordered in our labs are bilirubin, the total and direct bilirubin, and the transaminases. So for bilirubin, usually it depends on what type of bilirubinemia is seen, and it points out to a specific disease. So it can be an overproduction disease, such as a hemolytic anemia. Unconjugated bilirubin is produced at rates that exceed the ability of the liver to clear it, leading to a usually transient increase in unconjugated bilirubin in serum, which is usually massive in both Krigler and Gilbert syndromes. Mutations in the gene encoding UDP, glucuronyl transferase, result in buildup of unconjugated bilirubin in hepatocytes and ultimately in the serum, which leads to a mild hyperbilirubinemia. And mutations in the MRP2, CMOT, ABCC2 gene results in defective secretory proteins, causing buildup of conjugated bilirubin in hepatocytes and ultimately in serum, resulting in Lubin-Johnson syndrome, or which is an autosomal recessive disease. And can also have a conjugated hyperbilirubinemia, and the following diseases can be considered. Okay, so now we go to the more common test, which is the transaminases. So, and we see this is just a summary of where your transaminases are found within the cells, no? Within the hepatocyte and the bile canaliculi. Okay, so these transaminases are not just exclusive to the liver. So ALT can be found in the liver, the kidney, and muscles. And AST is usually found in the liver, cardiomyocytes, and all these other organs. And transaminemia maybe is sensitive for liver injury, but then you have to remember that it's not specific. So um, yeah, it can also occur in other diseases that are non-hepatic, especially if you have hemolysis, rhabdomyolysis, knowing that all these transaminases also occur in other organs of the body, and then even in anorexia nervosa, bowel infarction, celiac disease, among others. Okay, so these are the normal values. It's different from males and females, for males and females, and it is usually affected by exercise. So the level decreases to 20% after strenuous exercise for ALT, and it's the reverse for AST. It is elevated threefold after strenuous exercise. So acute liver injury leads to a high immediate rise in AST, which is subsequently supplanted by increasing and longer half-life ALT. So in alcoholic liver disease, there is increased mitochondrial release of AST with decreased ALT uptake due to pyridoxine or B6 deficiency. So both AST and ALT are significantly lower in renal failure. Next is alkaline phosphatase, which is one of the tests that can be not always routinely ordered, but is still often ordered. It is an isoenzyme that can be found in the liver, the bile duct epithelium, the placenta, and the intestine, and kidneys, and the white blood cells. So the rate of formation of P-nitrophenol is measured in testing alkaline phosphatase, and the half-life is as follows, and as well as the variability. And take note that alkaline phosphatase levels are usually higher in children and in pregnant women, and the levels of alkaline phosphatase are not affected by exercise. So elevated ALP with hepatobiliary findings usually points out to a primary liver disease. So so chronic cholestatic diseases such as your primary biliary cholangitis, primary sclerosing cholangitis, and drug-induced liver injury can produce elevated alkaline phosphatase. So, and then it can also happen in infiltrative diseases such as sarcoidosis. In our setting, it can be TB of the biliary tract or TB of the liver, chronic granulomatous disease, and metastatic diseases that cause elevations in the levels of alkaline phosphatase. And it can also be elevated in space-occupying lesions. So in obstruction of the biliary tract by stones in the ducts or ductules or by infectious processes, usually this results to ascending cholangitis or by space-occupying lesions. The biliary tract ALP rises rapidly to value sometimes in excess of 10 times the upper limit of normal. The rate of increase actually is very important. If you can figure out how much the level of increase of your test compared to the upper limit of normal, if you can see if it's just 5 times, 2 times, 10 times, that is actually a value. And for me, when diagnosing liver disease on slides, I'm not supposed to mention biopsies as I was told. I really look for how much I always correlate with the clinical data as well as the biochemical and laboratory findings of the patient imaging, because it really helps come to a short list of differentials when I see the level of elevations of the liver tests. So, so the reason for the increase in alkaline phosphatase for infiltrative diseases and chronic obstructive diseases include a combination of increased synthesis and decreased excretion of alkaline phosphatase. Okay. So ALP isoenzyme analysis is by electrophoresis or concurrent GGT and 5-nucleotidase levels should be analyzed to determine if the elevated ALP levels are of hepatobiliary origin. So an elevated ALP, an isolated ALP elevation does not always point to a liver disease. There has to be concomitant increase in your GGT or gamma glutamyl transferase and or 5-nucleotidase to say that the levels of ALP are elevated secondary to a hepatobiliary origin. So the pattern of injury can be determined using the R ratio. So this is derived from the patient's ALT over the upper limit of normal for ALT divided by ALP over the upper limit of normal for ALP or alk-phos. So an R ratio that is less than 2 presents with a cholestatic pattern. Between 2 to 5 corresponds to a mixed pattern, and more than 5, a hepatocellular pattern. So I find myself using this R ratio very often. I find it very helpful, especially when when you receives when you receive biopsies uh, in service, because they normally don't give any history, just the age and the sex. and and you at least have the power of being able to retrieve the uh, the the results of the patients in your lab. So and with once you categorize uh, that particular case in in a in a pattern, you can come up with a short list of differentials. So you can go through a short list of differential that can guide you in looking into more specific tests that can lead to the diagnosis, or even just ask the right questions from your clinicians. Yeah? So for me, the R ratio is a useful guide when I read liver biopsies. It leads me to a diagnosis or short list at least that is both histologically and clinically relevant. So personally, I never read liver biopsies without looking into the patient's liver test. So I look at the biopsy first, determine the predominant histologic pattern, and look into the liver test and see if it fits the diagnosis or the pattern I have in mind. So notice that in this table, drug-induced liver injury is under all patterns. And this is because different drugs have different mechanisms of injury and target different areas of your hepatic participation. Okay, so these are the other liver tests that are often ordered. So as I've mentioned, gamma glutamyl transferase to back up alkaline phosphatase when it's abnormal, to verify if the disease is really coming from the liver. Some tests of synthetic liver function like albumin, PT, INR, no, which can also measure the severity of your liver disease. Autoimmune tests no, that measures the activity, autoimmune activity like your serum protein electrophoresis, immune electrophoresis, and also um, platelet count and blood ammonia that measure the severity of the liver disease. Na? So we know that once platelet count is low, it also portends a very great prognosis. Okay, so GGT uh, regulates the transport of amino acids across cell membranes by catalyzing the transfer of a glutamyl group from glutathione to a free amino acid. So the half-life and the normal values are as follows. And it is usually elevated in chronic alcohol abuse. So these are the diseases where you can have elevations of GGT. Notice that if the disease is biliary in origin, alkaline phosphatase and GGT are usually elevated. So, okay, 5-nucleotidase, which is a test we don't frequently use, is a phosphoric monoester hydrolase, and and the function of which is for extracellular adenosine production. nutrient absorption and cell proliferation, and it is used to determine the source of an elevated ALP, whether it's really from the liver or from other organs or bone. Okay, so the principle of how it's measured, it's normally present at low activities in children and rises in adolescents and plateaus until age 40 when levels increase significantly. Okay, so albumin is an index of liver synthetic function, produced 120 milligrams per kilogram per day, and its synthesis is increased by low plasma oncotic pressure, and the normal half-life is 3 weeks. So when the patient has hypoalbuminemia with hepatobiliary findings, usually this is secondary to a decrease in liver synthetic function. But isolated hypoalbuminemia can point out to a non-hepatic cause. So what non-hepatic causes can be seen in either be in the form of malnutrition or a protein wasting diarrhea. So coagulation tests are also a measure of the liver synthetic function. So the prothrombin time measures hepatic synthetic functions and factors 2, 5, 7, 9, and 10. And it is the time taken for a plasma sample to clot after tissue factor addition. The INR is, we use the standardized results due to the variation between batches and manufacturers or tissue factor. INR was introduced. So the ratio of patient's PT to a normal control or control sample is raised to the power of the international sensitivity index value of the control sample. So a prolonged PT and INR tells us that more than 80% of the liver synthetic function is compromised. So relatively, PT and INR is insensitive for chronic liver disease only when it's more than 80% of the function is already compromised. And so, the PT and INR are compromised in vitamin K absorption. So these are the normal values. And PT, the platelet count, the platelet count is not only used in the CBCs, no, but it's also used by our hepatologists to compute for the APRI, the Forns test, and the fiber index test, correlating the biochemical values that they get from the lab with the degree of fibrosis that is seen in the liver. So aside from platelet counts, platelets are incorporated into different scoring systems to assess liver fibrosis. Okay, so the APRI, so you see the computation here, uses your platelet count, and whatever value is derived from that corresponds to the different METAVIR scores, which tells us how fibrotic the liver is. So the Forns test not only uses the platelet count, but the GGT. The fibro index test uses your transaminase, your AST, your platelet count, and your GGT. Okay, so these are the different scoring systems that are popularly used, and the scores are then matched with the different histologic scoring systems that are widely used. Okay, ammonia is derived mainly from amino acid and nucleic acid metabolism. So the liver uniquely contains the critical enzymes for the Krebs-Henselate or urea cycle, in which ammonia, a toxic substance, is ultimately converted into urea, a non-toxic compound that is readily excreted. So in this cycle, the enzyme carbamoyl phosphatase synthase is condensed with carbon dioxide and ATP to form carbamoyl in the rate determining that then is the rate determining step. So okay, so these enzymes are unique to the liver and is mainly used test for ammonia is mainly used for monitoring patients with liver cirrhosis and hepatic encephalopathy. So it usually when the ammonia levels are high, you again have 80% of your liver already damaged. Uh, and what is a better sample when you're trying to determine serum ammonia? We prefer the arterial sample rather than the venous sample because the venous samples do not accurately correlate with the mental status of the patient. Okay, so okay, this is just the method or what is really measured. And there can be variability in the ammonia levels depending if the patient fist was clenched, if there was a tourniquet used, and how long the tourniquet was there, and if the sample was placed in ice. So the value of ammonia again is in monitoring the development of hepatic encephalopathy. Okay, so these are other tests that are ordered only and uh, these are fixed and they are not just ordered unless it is really an important part of the differential diagnosis because these tests are normally not uh, readily available in all laboratories or uh, are quite expensive. Okay. So metabolic liver disease, if one is considering that, the following tests are also requested. And HOMA means homeostasis model assessment of insulin resistance. But in reality, that's a test that they use for non-alcoholic known as metabolic uh, so it's MASH now. MASH. So metabolic associated steatohepatitis. Um, yeah, steatohepatitis. Okay. So acute liver injury, one would usually in acute liver injury as compared to chronic, no one usually sees abnormal liver tests for less than 6 hours without pre-existing liver disease. 6 months, I mean, that is less than 6 months without pre-existing liver disease, and acute hepatic failure or fulminant hepatic failure, depending on your generation. Now we call the term is actually acute hepatic failure. Yeah? Acute liver injury with coagulopathy and encephalopathy is usually seen. Okay, so this is an algorithm um, for acute liver injury, and this is usually what we do. Okay, so okay, for chronic liver disease, the abnormal transaminase levels or ALT levels are have been present for more than 6 months, or there's histologic features of chronic liver disease. Okay, so it would usually present with a hepatocellular pattern with elevated transaminases, 1 to 4 times the upper limit of normal. So in these cases, the liver biopsy is performed to assess the degree of fibrosis and presence of cirrhosis and confirm the diagnosis of chronic liver disease. But there are also other non-invasive measures such as your FibroScan that can supplant the utility of your liver biopsy. Okay, so this is the usual algorithm that is followed. Okay, by our clinical colleagues. So the presence of a cholestatic pattern uh, mandates exclusion of obstruction in the biliary tree by imaging to exclude intrahepatic and extrahepatic biliary dilatation or the presence of tumors or masses in the along the tract. So in the pancreas, ampullary tumors, cholangiocarcinoma, etc. in these patients. Okay, for viral hepatitis, we will not go into this a lot, no, because we do experience and see it a lot in our labs. AST is usually over ALT elevation is greater than 5 times the upper limit of normal, and the alkaline phosphatase elevation is less than 3 times the upper limit of normal, except in the case of hepatitis A, which presents with a predominantly cholestatic pattern. So again, when you have a cholestatic picture, whether in biopsy or clinically, your alkaline phosphatase will always be elevated. So just a table summarizing the different hepatotrophic viruses. Okay, and just to remind you that not all viruses uh, are caused by the hepatitis alphabet. No? So not you can also have liver diseases secondary to your cytomegalovirus, as well as your infectious mono or EBV virus. No? So here the diagnosis will be different. The mode of diagnosing it would, in the laboratory will be different by using a monospot test or EBV capsid antigen IgM antibodies. Autoimmune hepatitis usually presents with increased serum globulin fraction, and there immunoglobulin G, and you have the presence of detectable autoantibodies. So in the determination of autoimmune hepatitis, our clinical colleagues usually use a scoring system wherein they give specific scores to the levels of ALT, the presence of ANA, the presence of IgG, as well as the features, the histologic features that are seen on the biopsy, whether they are typical or suggestive of autoimmune hepatitis. So drug-induced liver injury has a very variable pattern of liver injury, as I've shown you in the table before. So certain drugs have signature patterns that help identify them as a causative agent. And really, it is a very long list. I don't even memorize it because it's several pages. And again, since drug-induced liver injury will have different manifestations even for different people, the list keeps getting longer. So acetaminophen or overdose, for example, usually has high transaminases up to 100 times the upper limit of normal and would lead to renal failure in 10 to 15%. Okay, so hereditary hemochromatosis is a mutation of your HFE gene. And there is hemosiderin deposition in hepatocytes. And if it is untreated, it can lead to fibrosis and cirrhosis. And there is a high risk of hepatocellular carcinoma. So usually we measure the transferrin saturation, serum ferritin levels, and liver function tests. Okay, so Wilson's disease is a mutation of ATP7B gene, and there's accumulation of copper in the tissues, and it has a variable presentation. The diagnosis is clinched by the presence of ceruloplasmin greater than 20 milligrams per deciliter with the presence of Kaiser flexure rings. So copper excretion for 24 hours is usually more than 100 grams. For alpha-1 antitrypsin deficiency, although this is not very common, but it is also worth mentioning, there is also a variable pattern of liver injury, and usually what is used to diagnose it is at AAT levels that are below 50 to 80 deciliter with abnormal proteins. Okay, so PBC, primary biliary cholangitis, is no longer called primary biliary cirrhosis, but primary biliary cholangitis. There has been a name change. It's a chronic progressive granulomatous destruction of interlobular bile ducts that presents with fibrosis, also an increased risk of hepatocellular carcinoma, usually seen in women more than 50 years old. But the youngest case reported is 25. It presents with a cholestatic pattern, and the diagnosis is clinched by the presence of antimitochondrial antibody. In some cases, the clinical picture looks like an PBC. The AMA is negative, but once you repeat the test in a machine that is more sensitive, or a test that is more sensitive for the M2 fraction, um, that usually turns out to be positive. So before, they would call it autoimmune cholangitis, autoimmune cholangitis. When they call an autoimmune cholangitis, wherein there is a negative AMA, it's actually a PBC that still had very low levels of AMA. Okay. PSC, or primary sclerosing cholangitis, is a progressive stricturing of the large intrahepatic and extrahepatic biliary tree. It has a cholestatic pattern, and what clinches the diagnosis is the abnormal MRCP or ERCP. So that is the gold standard for. In overlap syndromes, you can have these diseases usually present with mixed pattern of injury. So there's chronic hepatitis with mixed pattern. No, so this can be seen in chronic drug-induced liver injury, or in overlap syndromes such as PBC or PSC with AIH, and this can also include your viral hepatitis, no? HCV plus AIH, or HCV plus PSC, whatever you want to add together. So, which actually, when it's combined with a viral hepatitis, it's more of concomitant disease rather than overlap syndromes, because all these three, PBC, PSC, AIH, they are your autoimmune cholangitis, no? So, or part of that spectrum, part of that spectrum of autoimmune cholangitis. And usually these overlap syndromes independently demonstrate both biliary disease and autoimmune hepatitis, and they also present with corresponding positive serum antibodies. Okay, so one also has to take note that there are changes during pregnancy in the liver tests or liver enzymes, and the elevated ALP during third trimester is secondary to your placenta, the leakage of the placental ALP into an increased maternal bone turnover, hypoalbuminemia, so there's hemodilution secondary to volume expansion. Gallstones can also increase because of can also be present because of the increased bilithogenicity and impaired gallbladder motility in pregnancy. And there's also a risk of in pregnancy. We consider this as a relatively immunocompromised state, and there is a risk of fulminant hepatic failure from acute hepatitis E virus and HSV. So, since pregnancy is a procoagulant state, there is a high risk for developing Budd-Chiari syndrome. Okay, so any elevations in transaminases, bilirubin, GGT, indicates a hepatobiliary pathology in patients who are pregnant, and the differential diagnosis is often guided by gestational age. So, in the first trimester, it can be because of your hyperemesis gravidarum, and you can take note of the elevated transaminases, and there will also be slight elevated bilirubin. Normally, we don't see a liver biopsy in these cases, and usually just supportive treatment will do. The second trimester, it can be cholestasis of pregnancy. There can be deposition of the bile salts under the skin, causing itching. There could be elevated bile acid levels and elevated transaminase levels. It can be normal GGT. Usually, we never see biopsies from pregnant patients, no? But it would present with bland cholestasis, and this is usually just treated with ursodeoxycholic acid. Third trimester, uh, uh, could point to the presence of preeclampsia, especially when there is hypertension, peripheral edema, and proteinuria, or eclampsia when there is preeclampsia with onset of seizure and coma. So both are associated with elevated transaminases and alkaline phosphatase. In the third trimester, you can also have the HELP syndrome, and you also have thrombocytopenia, in addition to the signs of preeclampsia and marked elevation in transaminases. So in the third trimester, you can also have acute fatty liver pregnancy, and it's a decompensated liver disease, and it may not have features of preeclampsia and HELP syndrome, but you also see decrease in the synthetic functions of the liver. There's prolonged PT and low fibrinogen levels. And so how I always remember it is that if the synthetic functions of the liver are deranged, um, uh, you are near the time of saying goodbye. So, okay. So, okay. So now we go to the other systemic diseases that cause liver tests to be abnormal. So liver tests may be abnormal in diseases primarily involving organs other than the liver, such as the heart, um, intestines, systemic diseases, endocrine disorders, as well as with neoplastic processes do not directly involve the liver. So therefore, when screening, serology, and diagnostic imaging are negative for primary liver disorders as a cause of abnormal tests, consideration should be given to evaluate for a systemic disease with liver involvement. So, because in most cases, the primary or underlying condition is already known, abnormal liver tests do not automatically call for a liver biopsy. So the latter is only performed when there is a known association with liver disease that needs to be excluded or that needs an assessment of severity. So knowledge of liver involvement is therefore very important for an accurate diagnosis and histologic interpretation when a liver biopsy is performed. So in some instances, as with ischemic hepatitis or congestive hepatopathy, definitive and distinctive histologic changes may be seen in addition to abnormal liver tests, but other diseases give rise to elevated liver tests uh, either without any accompanying histologic changes or minimal nonspecific changes, or often referred to as nonspecific reactive hepatitis. So the latter refers to a variable constellation of histologic findings that include minimal to mild portal lymphocytic inflammation with no interface hepatitis. So it's very varied. So liver test abnormalities are usually mildly elevated in a hepatocellular or mixed pattern in these diseases. So this is a summary of the other systemic diseases that show liver involvement. Okay. So connective tissue disease, such as your systemic lupus erythematosus, erythematosus, rheumatoid arthritis, Sjogren's syndrome, and scleroderma are immunologically mediated disorders that typically present with multi-system involvement. Although clinically significant liver involvement is rare, liver enzyme abnormalities are reported in half of these patients. And these are typically mild and transient, and histologic abnormalities are usually non-progressive. So if the uh, if the disease is controlled, usually the liver enzymes also um, are also controlled or go back to normal. So, okay, so patients with RA frequently reported to have liver abnormalities and even sometimes the presence of hepatomegaly. Okay. So can have abnormal liver tests, hepatomegaly, and if there is splenomegaly and neutropenia, this is called Gürfelti syndrome. So liver test abnormalities persist despite optimal treatment or underlying connective tissue disorders. One can consider maybe another disease, no? So on top of it. So liver involved, there can be more than just the abnormal or the connective tissue disease causing the abnormality or elevation in the liver enzymes. So uh, also try to consider that, yeah, on top of your connective tissue disease, the liver enzymes can be elevated in addition to drug-induced liver injury secondary to the drugs being used to treat the disease. Endocrine disorders also presents with abnormal liver tests, uh, and in a variety, and this is seen in hyperthyroidism from Graves' disease, and this is associated with liver enzyme elevation in up to half of untreated patients. These patients have elevated serum T4 and presence of serum thyroid receptor antibodies. So Addison's disease can be a cause of unexplained hypertransaminaemia and profoundly increased ferritin levels. Often these patients have associated non-specific severe abdominal symptoms, hemodynamic instability, electrolyte imbalance, and weight loss, leading to delayed diagnosis. Okay, so diabetes, mellitus type 2, and this is where I also include NAFLD or MASH. Okay, diabetes mellitus type 2 with other features of metabolic syndrome is associated with MASH. Now, these patients may present with hepatomegaly, fatty infiltration, that can be obvious in imaging studies with normal or mildly increased transaminases, typically less than 100 units per liter. And the enzyme levels are greater than 300 uh, units per liter are unusual. And if you have elevations greater than 300 units per liter, they are unusual and prompt workup for concomitant liver disease. So these enzyme values fluctuate and may rarely be associated with an increase in alkaline phosphatase. Type 1 insulin-dependent diabetes is associated with hepatomegaly uh, and liver test abnormalities. So usually you also see a bright liver on imaging here, not because it's filled with fats, but it's filled with glycogen. So, okay, so that's why it's also called glycogen hepatopathy. So liver test abnormalities usually show a hepatocellular or mixed pattern of injury, and this may be elevated up to 10 times the upper limit of normal. And histologically, you can determine that by the presence of a ground glass appearing cytoplasm. You can also have giant mitochondria, etc. So, and the biochemical and histologic findings improve with glycemic control. So, infectious diseases, infection and sepsis can cause cholestasis, and it often occurs in patients hospitalized in ICUs for gram-negative bacteremia complicated by hemodynamic alterations requiring vasopressor usage. The diagnosis is based on marked elevations in serum bilirubin with modest elevations in LDH and liver enzymes. So recovery is usually protracted and improves with antibiotic therapy, and persistent liver test abnormalities are associated with worse outcomes. So, um, so there is also this term called cholangitis lenta, and this is associated with sepsis as well. It is an unusual manifestation that is characterized by the presence of periductal cholangiocytes and inspissated bile within dilated and proliferated portal and periportal ductules. So what I was taught was if you see cholangitis lenta in a liver biopsy, even if the uh, patient's liver functions are not yet deranged, within the next 24 hours, the patient will go into septic shock. So okay, that yeah. So okay, with they also found out that when you withhold parenteral nutrition for more than 1 week, so we know that there are also several issues with parenteral nutrition. You can increase the plasma bilirubiin. It increases plasma bilirubin, but it also reduces the occurrence of biliary sludge, and it is also associated with lowered serum alkaline phosphatase and transaminases. Behçet's disease is characterized by a triple symptom complex of recurrent oral aphthous ulcers, genital ulcers, and uveitis. So it is characterized by chronic recurring lymphocytic vasculitis targeting the vasa vasorum and other small blood vessels, which affect veins more than arteries. So usually the most common complication that we see in these patients uh, involving the liver is Budd-Chiari syndrome occurring from hepatic vein vasculitis. So for neoplastic diseases, it can present with either cholestatic or mixed pattern, and this is actually very interesting. So sometimes the paraneoplastic uh, manifestations, such as cholestasis, helps you look into uh, or look further into the patient's clinical history and physical examination. So sometimes it's an indicator that something, neoplastic growth is present when you have high bilirubins, when you have cholestasis. So the liver is a common site for metastasis from a wide variety of neoplasms and is often involved as part of multi-organ hematologic malignancies. So abnormal liver tests in cholestatic or mixed pattern may result from compression of the bile duct or invasion of the portal or hepatic veins from tumors do not directly invade the liver. So the imaging studies are usually helpful. Normally, they do not require a liver biopsy except if the only presentation is cholestasis, and much less frequently is paraneoplastic involvement of the liver, particularly with renal cell carcinoma and malignant lymphoproliferative diseases such as lymphomas that can induce a reversible form of cholestasis through mechanisms that are not completely understood. So, Stoffer, syn- um, Stoffer syndrome is a rare paraneoplastic manifestation of RCC. Uh, that is characterized by elevated serum alkaline phosphatase, total bilirubin, and gamma glutamyl transferase, thrombocytosis, prolongation of prothrombin time, and hepatosplenomegaly in the absence of hepatic metastasis. So really all the tests points out to a liver disease now, and it's not really the liver's fault. Okay. Okay, so other paraneoplastic manifestations can be liver involvement in Hodgkin's lymphoma, can be common, it is common, and could be secondary to hepatic infiltration or biliary obstruction by lymphoma, hepatitis, sepsis, or DILI from chemotherapeutic agents. And usually here we also see the vanishing bile duct syndrome because of the prolonged cholestasis. Um, and this is a rare finding. It's reported as a rare paraneoplastic manifestation of Hodgkin's lymphoma, in which cholestasis and loss of bile ducts are seen in the absence of a malignant infiltrate, and the mechanism of which is poorly understood. Okay. In cardiac diseases, it can also have hepatic manifestations, including ischemic hepatitis and congestive hepatopathy. The pathophysiology of ischemic hepatitis is also known as shock liver. It is poorly understood, but it's thought to result from a combination of reduced hepatic blood flow and passive congestion of liver from underlying cardiac disease, and the patients usually show sudden and dramatic transient increase in serum aminotransferase that is more than 100 times the upper limit of normal, and LDH levels and bilirubin following periods of hemodynamic instability or hypoxia. It improves rapidly, usually within 7 to 10 days. Once the cardiac disease is stabilized and the diagnosis is usually apparent clinically, if a liver biopsy is performed, it shows usually a perivenular zone 3 necrosis of hepatocytes. So, um, case. So cardiac disease may also manifest as right-sided failure that leads to congestive hepatopathy uh, due to increased stasis and backflow pressure along the venous system. The liver test abnormalities show a mixed pattern of injury, but predominantly with elevations in alkaline phosphatase. So these levels may fluctuate with an associated increase in PT and INR and correlate with severity of heart failure. So liver biopsies rarely performed here, and there are varying degrees of hepatic, venular, and centrilobular sinus dilatation. So, okay, gastrointestinal diseases. There's a predominant prevalence of liver test abnormalities is rarely high. Prevalence of liver test abnormalities is rarely high in certain gastrointestinal disorders such as IBD and celiac disease, but the development of severe liver injury is exceptional. So, uh, most alterations of liver tests are mild and related to activity of the primary disease with spontaneous return to normal values. So there you have mild liver test abnormalities, mainly presenting as uh, an elevation of less than 5 times the upper limit of normal. Okay, and half of um, half of untreated patients with celiac disease can present this way, and these usually resolve after 6 to 12 months of a strict gluten-free diet. Uh, One also has to consider patients who have IBD may have concomitant PSC or concurrent PSC, and that would really up your or make your liver test abnormal. So, as prior studies have shown us that up to 10% of IBD patients have coexisting PSC. So, and then also, we look into parenteral nutrition associated liver disease. So this is characterized by hepatic steatosis, progressive hepatic fibrosis that could evolve into end-stage liver disease. So it is estimated that up to 40% of patients receiving TPN, long-term TPN, develop PNOD. And although the exact pathogenesis of this is still unclear to us and probably multifactorial, there is accumulating evidence that the lipid component of TPN is the most probable cause. So PNOD should be suspected in all patients receiving TPN in hospital or at home, and the pattern of injury is often mixed pattern or cholestatic. In most cases, elevated liver tests are observed after the first 2 weeks of TPN, and although some patients may develop abnormalities several months later. Okay, so it can have initially can have uh, hepatic steatosis histologically, and the second pattern that comes in is a biliary ductile action. It progresses to hepatic fibrosis, and the second is a biliary pattern with ductile action, and that also leads to hepatic fibrosis later on. Initially periportal, and then very minimal necrosis and no evidence of fatness. So here they can also present with ground glass cells, etc. Okay, so that ends my lecture, and um, I'd like to take advantage of the of this chance, um, of this opportunity to thank our fallen general. So our chairman in Makati Med, in behalf of the consultants, residents, and staff of the Makati Medical Center. So he made Makati Med such a happy place for us to work in. And it was such a good place for us pathologists to grow. So actually, I feel like we did not just lose a great pathologist. We lost a great mentor, a great colleague, but we also lost a strong support, a person who listens and solves our woes. He knew all our complaints. We can rant to him anytime. And we lost a source of joy and confidence and a wellspring of kindness. So rest in peace, Dr. Avila, and we will really miss you. So thank you so much for your time, and I wish everyone a fruitful convention.